See.
How will he will give countdown?
Signal for going live?
No, not yet. Yes, not yet. Yes.
What?
Rishi, we can go live now.
I have a feeling he can't.
Yes. He has given a chat. Yes.
Okay. I think it's not being heard. Okay. So welcome everybody to today's webinar brought to you by the Orthopedic Research and Education Foundation through OrthoTV. And today we have the pleasure of having with us once again Dr. Dhiren Ganjwala. And by now, I think he needs no introduction to this group because he's done a few webinars already. And today he's going to talk to us about pediatric osteochondral lesions. Again, a wide variety of problems which we have to deal with from time to time. And it should be a very interesting and exciting session. So over to you, Dhiren, without much ado.
Yeah, I think my slides are visible.
Yes, we can see.
Yes, sir.
Yeah. Good evening and thank you very much, Orthopedic Research and Education Foundation and OrthoTV for this opportunity. Now, in this presentation, I'm going to speak on osteochondral lesions, or the other name is osteochondritis dissecans. I would prefer the name osteochondral lesion because it tells us where the pathology is. While when we talk of OCD, we don't know what is the actual pathology. So first of all, let me tell you that my understanding is bit basic one, but this will be very useful to you because I don't operate patients arthroscopically. So I will try to give you the idea, the concept, how we deal with this condition. So first of all, let us understand what is osteochondral lesion. As the name suggests, osteo means bone, chondral means cartilage. So we understand that there is something wrong with the cartilage and bone. So the primary pathology is the subchondral bone, the bone which is underneath the cartilage, becomes avascular. Ultimately, the part which has become avascular will regains vascularity. However, that process is slow and sometimes it may not be complete. So that is about the basics. But before that, we understand the pathophysiology. Let us have a few basics about OCL. There are two varieties. The first variety is seen in children. We call it juvenile variety. And then there is a adult form also, which we've seen a person who is around 30 to 50. So today we are going to focus mainly on juvenile variety. This condition is mainly seen, the juvenile variety is seen between 10 to 16 years of age. It's not only at the knee, but it is seen at knee, ankle, elbow, shoulder, and hip. But today we are going to restrict the rest of the lecture on the knee. And in the knee also, the medial femoral condyle is more likely to be affected. The prevalence or the incidence of this condition is very less. It's
8 बजे कॉल करते हैं
8 बजे
हाँ
2 to 18 per 1 lakh. So that says that it's a very uncommon condition. And many of us, particularly the fellows, they see 2 or 3 cases of osteochondral lesion in their residency. The next question, which is very important, and everyone in the exam also, it's about like, why does it happen? Or about the etiology. Let me tell you very frankly that we don't have the clear understanding. We still proposes a lot of possibilities. So let us see one by one. The first is the trauma. It's either a single major trauma or a micro repetitive trauma. Both of this pathophysiology or the pathology is considered to be the cause of this condition. The second is ischemia, because we know that the vasculature or the blood supply of the subchondral bone is very different and it is vulnerable for ischemia and loss of vascularity. The third pathology is inflammation. And the fourth is accessory navicular center of ossification. So these are the primary mechanisms which can lead to osteochondral lesion. There are few biomechanical factors also considered in the mechanism. The first is it is more common in obese children. Those who are having a lower limb malalignment are vulnerable to this condition. And sometimes there is anatomical variation in the lateral femoral condyle, which makes it vulnerable for this condition. Again, posterior cruciate ligament morphology, when it's abnormal, it causes restriction or the reduction in the blood supply, and that may lead to this condition. Ischemia, as I said, like an intestine, here also we consider that the anastomosis is not proper, and because of that, that area is vulnerable for this mechanism. So, as I said, the subchondral blood supply has a poor arterial anastomosis, and that makes it vulnerable to this condition. There are other theories also, like vitamin D deficiency, which makes the bone soft. Again, growth hormone deficiency, which interferes with the ossification of femoral condyle. Whatever may be the reason, but ultimately these factors, they lead to a common pathophysiology. So we are going to understand this by few animations so that it becomes very clear in your mind why this condition happens. So to explain you this, this is a model which I will use. The yellow color is for the cartilage. And we are talking of the area which is adjacent to the cartilage. It can be on the femoral side or it can be on a tibial side. But for the sake of understanding, we will use only the medial femoral condyle. So as shown in this figure, the subchondral bone in the medial femoral condyle has become avascular. So this red area shows avascularity. Important point we need to remember is that the problem is with the subchondral bone, but the cartilage is normal. So the cartilage in the beginning of the process, the pathophysiology, cartilage remains normal. It's a disease of subchondral bone. In 50 to 67%, means 2/3 of the patients, the blood supply is restored. And in those patients, something like this, the one which we saw, over a period of next 2 years, the blood supply is restored. Those lesions which is smaller in size, they are likely to revascularize completely. And these patients, they become all right and they don't have any long-term issue. However, around 1/3 of the patients, in those patients, the blood supply is not restored fully, even with 2 years' time. And in those patients, the problem remains. And those are the patients where we need to treat them. So to understand that this is the subchondral bone which is not vascularized fully. And now what happens? The cleavage, this line of separation develops between the avascular bone and the normal bone. Because the density of both bones, the subchondral bone which is dead and the normal bone, they are different. And the junction works as a stress riser. And as shown over here, the subchondral avascular part gets separated from the normal bone. So this is what the primary pathology is, which is seen in the initial part. Later on, this continues and it extends into the cartilage. Because what happens, the cartilage has lost the support. When the loading comes, ultimately cartilage gets a lot of stress and there is a cleavage developed in this area. And then the next, the piece of cartilage and the bone, the subchondral bone, gets separated from the host bone, which is normal and vascular. This is from the internet. And this is a figure which shows that the lateral femoral condyle and the medial femoral condyle. And this is trying to show the inferior surface of the femoral condyle. And you can see that the osteochondral lesion is seen very well on the medial femoral condyle. We can see the crevices in the cartilage. And this is what the picture, the separated osteochondral fragment, we can see the piece of cartilage and the subchondral bone is separated from the host. Now the process continues. The child continues to run, walk. He may or she may have a pain, but ultimately the piece which is separated went on crushing between the two bones, the femur and the tibia, and ultimately the big piece gets converted into smaller pieces. And now these smaller pieces, they are able to come out of between the two articular surface, and now they go into the joint. They are free to move in the joint, and it irritates the synovial membrane. Basically, it's a part which is arise from the joint, but still when it comes in contact with the synovial membrane, it causes intense inflammation, and that inflammation leads to synovitis and a lot of fluid production, which cannot be absorbed, and it gets accumulated in the joint, and that's called the effusion. So what are the clinical features of these patients? The clinical features are, as we saw, the juvenile variety, the child's age is between 10 to 16, so it's an adolescent boy or a girl. The pain is gradual in onset. The pain starts gradually, and it is slowly progressing. Later on, there is a swelling, as we saw that when the piece gets separated, it leads to synovial irritation and joint fluid production, that is swelling. The other clinical features are, there is a effusion. There is a tenderness at the femoral condyle. So when knee is flexed and when you palpate on the femoral condyle, there is tenderness because that is where the lesion is. So to palpate the condyle, we have to flex the knee joint and then we have to look for the tenderness. The point which distinguishes it from any other condition that there is no tenderness at joint line. So if you examine in the extended position, there is no tenderness at the joint line. So that's a very important thing. Unless and until you press or like palpate the area which is affected, the person will not say that it's tender. What investigations are required? So for that, I will describe a case study. So that will give us an idea like which investigations are required. Let's talk about a case, a 12-year-old boy. He had a pain in the left knee joint for 6 months. There was a swelling over the joint, tenderness over the femoral condyle when patient presented to me. And these were the X-ray. X-ray were pretty normal. The boy was investigated for an inflammatory condition, something like juvenile rheumatoid and all that test. They all were negative. In 6 months duration, the second X-ray was also taken and that was also negative. Non-steroidal anti-inflammatory drugs were given and it reduces the swelling and pain temporarily. But as soon as we stop the medicine, both problems appear in the patient. So ultimately, when they presented to me by 6 months, I suggested them to undergo MRI. And this is the frontal plane or the coronal plane MRI. And we can see the classic lesion on the medial femoral condyle. If we take a sagittal section at this point, this is what the picture is. Again, we can see that there is a avascular necrosis in the subchondral bone. And if you carefully see, the cartilage is normal and there is no involvement of the cartilage is at this stage. So the point or the message I want to give from this case is In early case, X-rays or radiograph may be normal. So if you are suspecting this condition and if X-rays are normal, don't take it that way that it's okay. We really need to go for MRI, and MRI will pick up the lesion. However, in late cases, X-ray will also show changes. So MRI is required mainly for early case. In the late case, X-rays will show the changes. So this is a patient where you can see again in a medial femoral condyle on an inferior part, we can see the defect. This is another patient where we can see the subchondral piece of the bone is separated. Sometimes we may need to get a view with a knee flexion so that we can look at the inferior condyle, particularly the posterior part of the inferior condyle better. For the postgraduate, what are the differential diagnoses? We are looking at an adolescent age group. So in that case, the possibilities are the discoid meniscus. The meniscal tear can also be there. And sometimes we need to differentiate that this is not the patellofemoral maltracking, which is likely to be presenting at this age, and medial plica syndrome. So these are the possibilities we have to think. And MRI will definitely give us both clinical examination and MRI will tell us about the clues. And the another important point which I would like to emphasize to all the postgraduate, any patient coming with the knee pain, don't just focus on the knee. Think about the conditions of the hip also. The slip comital femoral epiphysis or a late onset perthes are the two conditions which we have to think. They are hip problem, but the child may present with pain in the knee joint. Okay, so now after understanding the pathophysiology, now we go to the most important part, and that's the treatment. And what I have done is like I have tried to explain you the treatment in a very simple, easy to remember way. So there are a lot of factors which decides treatment. The first factor which we need to remember is the age of the child. Where is the lesion? How it is can be approached. The third is how big is the lesion, and at what stage of the pathophysiology the lesion is. So means what is the stability of that piece? Is it still in situ, or it's the cartilage overlying it is intact, or there is a crevices in the cartilage, or it's separated. So all this decides what should be done. We need to remember that almost 2/3 of the children, they heal non-operatively. So non-operative treatment should be the first line of treatment for these patients. What are the indications of non-operative treatment? The asymptomatic patient who is athlete or who has a large lesion or who is just near the time of closing of the physis, means the growth is getting over. Or on the other side, there is a symptomatic patient, but the physes are open. These are the patients who should be considered for non-operative treatment. In phase 1, there are 3 phases which we need to remember. The phase 1 is up to the first 6 weeks. This is the protocol which Professor Mininder Cocker from Boston Children's Hospital, he popularized. So I'm suggesting that protocol. So in phase 1, which is up to 6 weeks, we need to give raise to the joint. And so we keep the child off the weight and immobilization is recommended. So 2 things, the partial weight bearing or off the weight completely, and we give a AKBK brace so that the knee range of motion is reduced. In phase 2, which extends from 6 weeks onwards to 12 weeks, we start gradual mobility, and also we have given immobilization, so muscles are likely to become weak, so we carry out strengthening exercises. Gradually from partial to full weight bearing is proceeded during this period, but it all depends how patient is behaving. After 3 months, again, once the full weight bearing is allowed, they are gradually returned to the spots. Now, in some of the patient, we have to go for a surgical line of treatment. And this surgical line of treatment, the most important treatment is drilling. What is the rationale and how it is carried out, that we will see with a few pictures. So what are the indications of drilling? When the lesion is in a very atypical location, when it's a large size, and we know that the larger lesions takes longer time for spontaneous healing with the non-operative treatment, or when the child has a mechanical symptoms which says that probably the piece has become unstable. So these are the indications where we have to consider for drilling. Or once we approach to the physis, or when we come to the end of the growth phase, these are the indications for drilling. So what we do in drilling? Now in this animation, the color of the cartilage is changed. So please understand that there is no problem with the cartilage, just the color of the cartilage is changed. We make a drill with 1 to 2 millimeter K wires, not from the joint.
No, it's not the photo.
So we carry out a drilling not from the joint, but basically we carry out it from the area away from the joint line. So this is how we carry out the drilling. Now what we are creating, we all know the concept about the core decompression, which we use it in the femoral head. We create a channel so that the process of revascularization starts. So we are making hole in the subchondral area so that the blood supply or the blood vessels from the adjacent area which penetrates this area, and the process of revascularization starts. Remember that this should not extend into the cartilage. We don't want to drill the cartilage. It is only the drilling of the subchondral area. What we discussed, the drilling is a wonderful treatment for the stable lesion because the cartilage is intact, the stability is not an issue. So we drill it, and that leads to increase in the vascularity. However, unstable lesions require something more. And let us see how we can treat those lesions. Usually with the arthroscopy, we decide what is the situation. If it's an undisplaced lesion, means the cartilage is partially intact. In that case, we carry out in situ pinning. We will see this with pictures. If it's minimally displaced, but piece is salvageable, means it's a piece which is intact, we can put it back. In that case also, we go for fixation. So here we have to bring the piece into the position, and then we have to fix. And the third thing is when it's unsalvageable, as we saw in the previous animations, when the piece of subchondral bone is broken into many pieces, we cannot salvage it. We have to remove all the pieces, and then we need to go for osteochondral graft. We will see what is that. So let's understand the first one, when it is undisplaced. So as shown over here, the piece of the bone and the cartilage is not displaced. And so we carry out a drilling to increase the vascularity. And then we pass 2 pins from the cartilage with the help of arthroscope, and then we try to fix it. So the reason for this pinning is to fix the loose piece. And drilling is basically to increase the vascularity. This is again a picture from the internet, and that very clearly shows that the piece which has been separated and it's fixed or reattached with the metal screws. So this goes with the help of arthroscope, and we are entering from the cartilage. The drilling is done from outside the joint or outside the cartilage area into the subchondral bone, but the pinning is done from the joint. Then comes the displaced but salvageable piece. Again, the same technique is carried out. This piece is aligned, brought into the proper position, and then again fixation with the pin is done. There are various varieties of pin. It may be a metal pin, it may be a biodegradable material, depending on the availability and the choice of the surgeon and the affordability of the patient, we take a decision how to fix it. And coming to the last part, which is unsalvageable piece, like this, which is completely separated and sometimes it's crushed so that there is no point of putting it back. In that case, we have to remove it. But remember that if you don't do anything after that, if you just remove the piece and don't fill the gap, then we have seen that phenomena. And I would like to give you a common example which we see. In a monsoon, on the road, when there is a pit, if you don't fill it immediately, what happens as the vehicle pass over there, it tries to take away the material from the edges, and gradually that area become bigger. So the next animation which we are going to see is going to show us that if you don't treat the lesion early, then it will lead to a secondary osteoarthrosis. This has a video, the audio in that. I'm sure I have checked that it will work properly. If it's not working properly, then please let me know. We will try to fix it.
Upon injury, a small cartilage tear may occur. Unlike most tissues, cartilage does not have the ability to heal itself. If untreated, cartilage injuries will progressively deteriorate. This deterioration can continue until the bony joint surfaces rub directly against one another, causing severe and often chronic pain and irreparable arthrosis.
So this video very clearly shows that if you don't treat this lesion, then it will lead to osteoarthrosis. And before the era or the availability of MRI, those patients who were coming to us with the early osteoarthrosis of the knee joint, probably they had osteochondral lesion which was not treated well in time, which was missed initially, and ultimately leads to secondary osteoarthrosis. And these patients present to us at, like, say, at the age of 45 or 50. So if we want to prevent the secondary osteoarthrosis, we have few options. So the first option is autologous osteochondral graft. Now we are going slightly at a higher level, so I will use more and more animations and pictures so that the concept become clear. So the first option is autologous, means we are taking from the patient's osteochondral graft, a piece of cartilage and bone together as a graft, and then we put it at the site of defect. The second is, the one advancement is autologous chondrocyte implantation. So as the name suggests, we are taking chondrocytes, the cartilage forming cells, from the patients, and then we implant them. But in between, we carry out the culture, we increase the number of chondrocytes, and once we have a sufficient number, we put them back. So that is called autologous chondrocyte implantation. There are 3 generations, and we will see one by one the video for them. The options, the third, which is not available in India, that's osteochondral allograft. We take a cadaveric graft and then we put it in the defect. At this stage, we don't have this facility available in India. Regarding the autologous chondrocyte, there are few controversies going on. So initially it was available, then government banned it, and now again it's possible. So let us understand the 3. So let us understand the first one, autologous osteochondral graft. So let's see that this is the part of the femoral condyle, which is avascular. And this is the defect which has developed. We can understand that if you don't do anything to this, ultimately it would lead to a medial femoral condyle osteoarthrosis, and that leads to a lot of problem or early osteoarthrosis. So what we do in this stage, the part of the trochlea which is not articulating with the patella, we take a graft of bone, both cartilage and the bone, that's the osteochondral graft. The cylindrical graft are taken from these areas, and then this is the instrument to take that graft, and then we put all this graft, depending on the size, we put them into the defect. So this is what the defect has been created after taking the graft. So these areas are basically non-articulating part. So this part of the joint is not articulating with any other bone. So we can take the osteochondral graft, and these sites work as a donor site. And this is what the filling of the osteochondral graft has been done. Ultimately, we are providing, we have to ensure that this is in proper level, and all the dowel or all the osteochondral graft are in a smooth surface. Otherwise, ultimately, there will be a lot of load on the part or the graft which is projecting up. So this is an animation which shows that how the graft is taken. With the instrument, we create a defect and then we punch the graft. Depending on the size of the lesion, the multiple grafts are inserted, and you can see that ultimately that forms. And the part or the gap between the graft, the dowel graft, will be filled with fibrocartilage. We are not going to discuss about the long-term results because I don't think that the postgraduate should focus on that part. I just want to clarify the idea or the concept. The second concept, which is the recent advances, is autologous chondrocyte implantation, ACI. In ACI, it's a two-stage surgery. In the first surgery, the cartilage, the piece of cartilage is harvested. So by doing an arthroscopy, the piece of cartilage is harvested, and then it's sent to the laboratory. In laboratory, the chondrocytes are separated. From the cartilage, the matrix is removed and chondrocytes are separated.
Arthroscopic surgery is a minimally invasive surgical procedure in which a visual inspection, examination, and repair of the joint is performed. Following the inspection of the joint and determination that the injury is within the indications for the autologous cartilage implant, the surgeon removes a small biopsy of articular cartilage from a non-weight-bearing area in the knee. The biopsy is placed into a sterile container with samples of the patient's blood, then securely transported to Procon's laboratory to enable a true autologous cell cultivation process. In Procon's dedicated cell processing facility, the cartilage-producing cells are released from the biopsy. The released cells are cultivated and introduced to Procon's proprietary chondrocyte expansion process. The unique combination of the patient's serum and Procon's growth factor signals the cells to initiate rapid proliferation while preserving their chondrogenic potential. There is no use of animal-derived components, thus removing any chance of their associated health risks. Within 10 to 14 days, the appropriate number of cells is obtained. The cells are evaluated for their cartilage production capacity.
So this is the first part has been over. Now, when the sufficient number of cartilage cells are ready, the laboratory tells the doctor that now the cartilage chondrocytes are ready for implantation, and the second stage of surgery is carried out. Now, this second stage has evolved over a time, and I'm going to describe each one in brief. So, In the second stage surgery, the chondrocyte and matrix are implanted in the defect. The defect which has taken place because of the lesion is first of all cleared, and then this chondrocytes and the matrix is implanted. In the first generation, means the technique which evolved first, after covering the chondrocytes, the area is covered with periosteum. So the periosteum is taken from the adjacent part, and then that area, the defect, is covered after implanting the chondrocytes. In the second generation, the technique improved, and instead of periosteum, the collagen membrane is used. So we don't create one extra surgery. Instead of periosteum, we use the collagen membrane. There is a video about that.
Is approached through a medial parapatellar arthrotomy. Care is taken not to harm the medial meniscus nor articular surfaces.
So this is a standard
Retractors are
arthrotomy
placed
procedure.
and the knee flexed to view the defect.
The defect is visualized.
A 15 blade is used to create vertical walls, and a curette clears the base. At this point, the defect is measured, the tourniquet is deflated, and fibrin glue is applied, and digital pressure is maintained to achieve hemostasis. The measurements are transferred to a template. The template is cut to fit the exact dimensions of the defect and marked for orientation.
This is a collagen membrane.
A collagen 1,3 patch has been hydrated. There's a rough surface and a smooth surface. The smooth surface is labeled with an UP or up, as you can see. The template is then transferred to the hydrated collagen 1,3 patch, and the patch cut to fit. Maintenance of adequate hydration is necessary to have the patch fully out to length. Cells are then resuspended, and in this case they will be seated on the rough surface of the collagen 1,3 patch. After 10 minutes, the cells will be adherent. During that time, they are protected. Hemostasis has now been achieved and reconfirmed. The seated patch is then placed into the defect with the rough seated area facing bone. Any extraneous patch is removed, and then the patch is sutured into place. 6-0 absorbable suture. Sutures are placed at 3 to 4 millimeter intervals and then further sealed with fibrin glue. A second vial of cells is injected, and the injection site is then sutured and further sealed with fibrin glue. After approximately 10 minutes, the area is irrigated and the incision closed in layers. Thank you.
So second stage is always an open surgery. Now there is a further advancement, and to avoid all these issues related with the suturing and all that, the third generation ACI came, and in that, instead of like chondrocyte implanted physically, they are inserted in the scaffold. So scaffold is a biomaterial in which the chondrocytes are injected, and then this scaffold is packed into the defect.
Cells are seated onto the cartomate scaffold, a three-dimensional, interconnected, open pore structure which provides a suitable microenvironment for the autologous chondrocytes. The cartomate scaffold is an all-natural, biocompatible structure that allows full distribution of chondrocytes, simulating normal cartilage and promoting tissue formation by maintaining cell differentiation and matrix deposition. The implant is then sealed in a double blister sterile package and securely transferred to the hospital for implantation. The BioCart implantation is performed via a minimally invasive surgical procedure. First, the surgeon prepares the cartilage defect area by removing degenerative or loose cartilage. The edges of the defect are trimmed to create a stable and healthy border around the lesion. The template is used to trim the BioCart implant to the exact shape and size of the cartilage defect. The implant is placed in the defect to confirm fit. The scaffold adheres to the lesion site due to its self-adhesive properties.
So with that, we don't need to suture the collagen membrane at that, and that saves a lot of time. So I would like to end my talk with few important points which we need to remember. The first, the prevention is not very effective in this condition because we don't know the exact etiopathology. We really need to make a lot of progress to understand why this condition occurs. Once we know that, probably we will be able to offer prevention to the condition. Early diagnosis is possible with the help of MRI. And that is a very important thing, that we make an early diagnosis. Because in that case, we can offer them a smaller magnitude of surgery like a drilling. Aim of the treatment is to prevent secondary osteoarthritis. Non-operative treatment is effective in almost 2/3 of the patient and should be tried first. Newer advances will improve the outcome, and I'm sure that the future is going to be very bright. So with that, I would like to stop sharing, and thank you very much.
Thank you, Dhiren. As usual, very clear and conceptualized. And so we'll open this for questions from the postgraduates and the DNB students.
Thank you very much, sir. So while we are waiting for the question, one thing, sir, about the presentation, if it is a early presentation, then what we need to do, and if it is late for a younger population.
So ultimately, I have not taken that into too much details because I really want to give the broad overview of the treatment. So early lesion, when there is no cartilage separation, we need to increase the vascularity. And for that, the drilling from the extra-articular site is the first line of treatment. So first is non-operative. If it fails, or if you feel that the lesion is large, in that case, we need to go for drilling.
Okay. So when it is a presentation with synovitis, like it's not in only in younger patient, because even in the middle age, sometimes patient present with synovitis, and as you advised, after the MRI, if it is diagnosed, then what is our plan of treatment?
Frankly, my experience about the adult condition is not more, but at least as I understand, the line of treatment is more or less same. The prognosis is somehow better in children than that of an adult, but otherwise the line of treatment, the concept, they are same for juvenile as well as adult variety.
So I think synovitis is a different problem altogether. So when you get synovitis, that means there's an inflammation of the joint, while the osteochondritis dissecans is really a non-inflammatory problem. Okay, I mean, you can get inflammation as a result of it, but that is not what you're treating by drilling and things like that. Okay, so that you'll have to treat with anti-inflammatory medication.
So your voice is.
So you'll have to treat that with anti-inflammatory medication, etc., and then see, because that's a different problem from the osteochondritis dissecans or osteochondral lesion that we are talking about, which is not an inflammatory condition.
Yes.
So only in the later part, when the piece gets separated and it's broken down into a smaller piece, then only the synovitis will be presenting.
Okay, sir. Okay, sir. So today we have the privilege of having Dr. Sudeep sir from AIMS, and 8 of the PGs from AIMS has joined.
Okay.
From one of them, Dr. Lakshya, has asked what are the other sites of photograph non-articular apart from trochlea, and if defect is large enough to fill, then what is the plan?
Okay. See, basically,
Non-articular, what does he mean by non-articular?
So
Because
if it is not
some
weight
people
bearing,
think they're
probably
not non-articular. It's articular but non-weight bearing.
yeah.
non-weight bearing. Yes, sir.
Yeah, sorry. So that's very important thing. It is basically inside the joint, but it's not in contact with the opposite bone. So we can say that it's a non-weight bearing area. So yes, that's a very important practical question. And at the most, you can go for the opposite side to take a more graft. But if lesion is large, I don't think that we have anything else to offer.
So I think
Nowadays,
if
grow, so they are, these are all to some extent experimental, where you include chondrocyte implantation, you culture chondrocytes to get that area. And there have been some promising results with it, but we still don't know exactly long term what their results are going to be. So we need to really watch the space. There's a lot of work going on towards this.
So I just would like to tell the PGs that once we say that the first generation, second generation, third generation, we need to understand that we are still evolving.
Yeah.
Time and again, we are developing it and making better and better, but still we are evolving. So this is probably the condition. After 15, 20 years, our understanding will be very different than what we have today.
so, as what is a scenario in India, sir? Because ACI we have seen. After that, you have shown some that is available in our country.
No, see, osteochondral graft is basically you take a graft from the cadaver. So at present, we have like say, it's possible to have a cadaveric transplant for the kidney. We can transplant cadaveric liver also. Means the brain dead person, we can shift it. Similarly, we can carry out the same thing for the femoral condyle. So what we do, we take a femoral condyle also, and according to the defect, we take a graft from that. So instead of patient creating a morbidity in the patient, we are taking a cadaveric graft. But we don't have a legal permission at this stage. So the third option, allograft, is not possible in our country.
So in fact, there are centers which are doing complete joint transplantations, okay? So the entire femoral condyle and the entire tibial condyle, but they have special methods of preserving these when they take it from the cadaver. Okay, so they have to be fresh, they have to be kept in that situation, and there are various. So the one of the places is Hanover, another one is the University of Missouri, I think, where they have a good center, okay, with Stannard there. So these places are actually doing complete joint transplantations, where the entire articular area of the femur and the tibia can actually be transplanted in a young patient who has lost it due to injury or something like that. But this is still still not available in India. Okay.
There is a very good video available on the internet about this, but because it is not available in our country, I did not show this video. Otherwise, if you go on the net and write down osteochondral allograft, you will see a wonderful video which explains everything.
So I've heard both Kretek and Stannard at various times talking about it and showing some very excellent results with this. So, but the main barrier is actually the storage of this cartilage this thing over a period of time. So you need to be able to have a bank which can give you this at the appropriate time to be able to do it. So tissue bank, which.
So I think we do not have other question, and one thing, that second part of this class will be like osteochondritis, as you can see in general, other than the knee, will be planned as soon as we'll give the date. And if any other question the PGs or Sudeep sir has, please ask. Sir.
No, it was a very nice presentation, Janki. So very useful for PG. So yeah, I hope they have learned quite a lot actually. Thank you.
Great. Okay, then. Thanks, Dhiren, as usual.
Yeah. Thank you once again for the opportunity.
Till next week. Bye to everybody.
Yeah.
Okay. Sure. Bye.
Thank you very much.
Thanks.
Bye-bye.
Thanks.